Hello everyone to the December 2024 edition of the Northwest Kidney Center monthly in-service. Merry Christmas and Happy Holidays to all of you. Today we're going to be discussing a very important part of the treatment of kidney failure, which is kidney transplantation. So why is this so important? Well, transplant is a much better treatment for end-stage renal disease than dialysis. Compared to dialysis, transplant improves quality of life, it reduces mortality risk, and it's much less expensive. Unfortunately, because of health problems and a limited number of available kidneys, not everyone is available to get a kidney transplant. So today we'll discuss who's a candidate and if they are, the steps involved in the transplant evaluation. From this talk, I would like you to appreciate the clinical benefits of kidney transplantation, recognize the contraindications to kidney transplant, and be familiar with the transplant evaluation process. Let's begin with a clinical review of the benefits of kidney transplantation. As you all know, kidney transplantation is a surgery that involves placement of a healthy kidney from a living or a deceased donor into a person whose kidneys are no longer functioning properly. We've been doing kidney transplants in this country since 1954, and the process is very streamlined. And there are many reasons to encourage our patients to receive a kidney transplant. For starters, there's much better quality of life associated with a transplant. You don't need to go to dialysis anymore. You can travel. You can enjoy fewer dietary restrictions. There's a lower risk of death. Some studies suggest an average increase in lifespan of 10 to 15 years with kidney transplantation compared to staying on dialysis. Additionally, there's also a lower treatment cost. Dialysis is much more expensive than the annual cost of maintaining a kidney transplant. But there are also some short and long-term risks associated with kidney transplantation. Some of the short-term risks include surgical complications such as bleeding, blood clots, or post-operative infection. Sometimes the kidney doesn't work primarily, or it could be rejected by the donor. Because of immunosuppression, patients have an increased risk of infection. They can even develop cancer, and they can even receive cancer from the donor if the donor had a cancer that wasn't detected before donation. There are many potential side effects associated with the use of anti-rejection medications. These include diabetes, the development of hypertension, high cholesterol, weight gain, acne, weakening of the bones or osteoporosis, excessive hair growth or hair loss, very common problems after transplantation, infection, and there's a long-term increased risk of cancer, particularly skin cancer and lymphoma. That said, most of us feel that the benefits of transplantation clearly outweigh the risks, but a lot of patients get very comfortable with dialysis and are apprehensive about proceeding with the transplant evaluation. That is something that we can potentially help them with. That said, not everyone in the dialysis unit is considered to be a candidate for transplantation. Let's begin by reviewing the absolute and relative contraindications to transplant. Many of these are obvious. First, let's discuss the absolute contraindications to kidney transplantation. Active infections are obviously a contraindication to kidney transplantation because of the need for immunosuppression, which could worsen a chronic infection. So for example, if someone has dental disease or a latent infection such as tuberculosis, the patient basically needs to be treated of all the infections or cleared of all the infections before transplantation. This is one of the reasons why a standard transplant evaluation includes say a chest x-ray as a screen for tuberculosis, a tuberculosis skin test, a dental evaluation. That said, not all chronic infections are contraindications if they have been treated or under control. So for example, hepatitis B and C, patients will usually need to be seen by a liver specialist to make sure that they don't have cirrhosis of the liver and be started on treatment prior to the transplant. HIV is not generally considered a contraindication to transplantation as long as the disease is controlled on antiretroviral therapy. Active malignancy is also an absolute contraindication to transplantation. If you have anything short of skin cancer, which usually can be treated with just excision, then a patient is not a candidate for a transplant, at least until they've been, verified that they've been in remission for several years. If you've previously had cancer, you have to endure a waiting period to demonstrate that you are free of recurrence, and that can be anywhere from 2 to 5 years. This is to minimize the risk of recurrence due to the use of immunosuppressive medications, because remember, your immune system also fights cancer. That said, there is marked variability in the period of time that people have to be on hold before receiving a kidney transplant if they've had cancer. So for example, if they had like a kidney cancer and they get their kidney removed, their native kidney removed, then they may be completely free of cancer and not have to wait at all. But for other cancers, you might need to wait anywhere from 2 to 5 years. Any active substance use disorder needs to be addressed and resolved prior to placement on the active transplant list. So for example, if someone has alcohol dependence or any other substance use disorder, they may be required to enroll in a rehabilitation program. They clearly need to remain drug and alcohol free, which can be confirmed by random drug testing. Different policies vary with respect to marijuana use by center. Some centers consider marijuana to be a contraindication. There are reasons for this, including an increased risk of fungal infection or pulmonary aspergillosis when inhaled. There's an increased risk of cardiovascular problems, peripheral vascular disease, and there is some concern for potential drug interaction between marijuana and the immunosuppressive medications. Most transplant centers require patients to quit smoking before transplantation. If they don't, they should. Transplant candidates are screened for tobacco use with serum creatinine levels. Uncontrolled psychiatric disorders are also contraindications to transplantation. These may include depression, psychosis, anxiety, any sort of mental health disorder that may compromise the ability of the patient's participation in post-transplant care, whether it's coming to appointments or taking their medications, will disqualify them from placement on the active transplant list. Any uncontrolled systemic disease is similarly a contraindication to transplantation. So for example, if a patient has active lupus or if they have a systemic vasculitis or inflammation of the blood vessels, these conditions need to be treated and put into remission before you can proceed with transplantation. Non-adherence with medications or dialysis therapy is also a major red flag for transplant programs and will disqualify someone for placement on the list. This is one of the many reasons why we need to encourage our patients to attend dialysis regularly. Transplant programs review dialysis attendance records, and if they don't come regularly, they will not be placed on the transplant list. So if you have a patient who's not coming to dialysis regularly and they're a transplant candidate, remind them that they need to show up for their treatments, otherwise they won't be able to get a kidney transplant. Severe cardiac disease that is not amenable to surgery is also an important contraindication to surgery. The main one is heart failure. So if you have severe heart failure on the basis of coronary artery disease or blockages in your heart arteries, and you have what's called an ischemic cardiomyopathy. And many studies have shown that these patients do very badly with transplantation, and most patients won't transplant them unless they're also a candidate for a combined kidney heart transplant. Similarly, severe vascular disease is a contraindication to transplantation. Some patients have heavy calcium deposits in their arteries, and if this occurs in the arteries in the pelvis, it could potentially prohibit a surgeon from sewing in a kidney transplant because the kidney transplant is sewn into the pelvic arteries. Okay, so that was a summary of the absolute contraindications of transplantation. Let's now discuss the relative contraindications. Recipient age alone is not technically a contraindication to transplantation. To use age alone as a disqualifying factor would be considered discrimination on the basis of age, which is not allowed. That said, a shortened life expectancy is a contraindication to transplantation, and of course, the older you are, the shorter your life expectancy. In this part of the country, it would be unusual for someone to receive a kidney transplant above the age of 75 years. It's still possible, but these cases are the exception rather than the rule. Malnourished patients generally don't do well with any surgery, so most transplant programs would recommend improvement of someone's nutritional status before proceeding with transplantation. Frailty is a relative contraindication to transplantation. So what is frailty? Well, it's a condition that's hard to define, but you instantly recognize it when you see it. And it's characterized by physiological decline with features including weight loss, fatigue, weakness, slow gait, low activity level. Frailty in a kidney transplant recipients has been associated with increased risk of delayed graft function, so the kidney doesn't work right away after it's planted, being readmitted to the hospital, longer lengths of hospital stay, increased risk of death. So there's no consensus among transplant programs as to whether or how to perform a functional assessment of a potential transplant recipient, but many programs use what is called the 6-minute walk test, in which a patient walks as fast and as far as possible in a 6-minute period, and the speed and distance are measured. Certain kidney diseases can occur following transplantation and are considered relative contraindications to transplant surgery. Many kidney diseases may reoccur in a transplant, reducing its lifespan. So for example, there's a condition called primary oxalosis. This is a condition in which the liver has trouble metabolizing oxalate, and levels accumulate in the blood and can precipitate within the kidney tubules and cause kidney failure. So that uniformly recurs after transplant, and so it's a contraindication unless someone also receives a liver transplant as well. And then there are also some forms of kidney disease that are caused by the immune system, and these can also recur after transplantation. Most transplant programs exclude patients for transplantation if they have a body mass index greater than 38 or 40. And that's because the presence of obesity is associated with an increased risk of adverse outcomes after the transplantation. For example, LaFranca published a study in 2015 that looked at over 200,000 kidney transplant recipients and compared them among recipients with and without obesity. And they found that obesity is defined by a body mass index of greater than 30, was associated with a significantly increased risk of death, delayed graft function where the kidney didn't work right away after the transplant surgery, rejection, wound infection, wound dehiscence where the wound splits apart and doesn't heal properly, and the development of post-transplant diabetes. Yen et al. In 2023 published a study that, again, it was an observational study that showed that obesity was associated with a 64% higher chance of loss of kidney function within 6 to 2 years after transplantation. So unfortunately, these contraindications eliminate a lot of dialysis patients from consideration of transplant, which is why only a small fraction of dialysis patients ultimately get approved for the procedure. In our clinic in Kent, for example, we only have about 14% of our patients below the age of 75 who are on the active transplant list, while the goal established by CMS, which is the Centers for Medicare and Medicaid Services, is at least 20%. So exactly who is a candidate? Well, a patient who doesn't have an active contraindication to transplantation and is interested in receiving a kidney transplant. So how can you help? Well, it's important to talk to our patients about transplant, try to get them interested. If there's an obvious barrier to transplantation, such as smoking or marijuana use, encourage them to quit. And as an aside, if you're not sure about someone being a candidate for transplant, ask a social worker who helps keep track of this data. For example, if the patient is 90 years old, it's best not to talk to them about transplant because that will give them a false hope. So what exactly is involved in a transplant evaluation? In other words, how do we get a patient approved to be on the active transplant list? If a patient is interested in transplant and does not have a contraindication, then he or she should be referred for a transplant evaluation. In the Seattle area, there are 3 transplant programs: University of Washington, Virginia Mason Medical Center, and Swedish Medical Center. The nephrologist is responsible for referring a patient to the transplant center for the evaluation, and the goal of the pre-transplant evaluation is to make sure that the patient is a reasonable candidate for both surgery and immunosuppression. The evaluation includes a thorough screen for major medical problems that could present a problem during or after the transplant surgery. And these include some of the problems that we've previously discussed. For example, cardiovascular disease, cerebrovascular disease such as a stroke, peripheral vascular disease, cancer, infection, lung disease, bleeding or clotting disorders, psychiatric disorders, and substance use disorders. Routine cancer screening is part of the standard transplant evaluation. This would include, say, a colonoscopy if someone is 45 years or above, a mammogram, or a pap smear for women. Cardiovascular disease is a leading cause of death after kidney transplantation and is also a major cause of morbidity and mortality in patients on the transplant waiting list. And this is why cardiovascular evaluation is one of the most important parts of the transplant evaluation. The evaluation includes an electrocardiogram. It's also abbreviated EKG or an ECG, which basically measures the electrical activity of the heartbeat. Also looks at something called an echocardiogram, which uses high-frequency sound waves or ultrasound to generate pictures of your heart. This test is also called echocardiography or a diagnostic cardiac ultrasound. And it gives us all sorts of structural information about the heart, including the size, the shape, the thickness of the wall, how well the walls move, how well the pump contracts, whether or not the valves that separate the chambers are working properly. If blood is leaking backwards through the heart, we call that regurgitation, or if the valves are too narrow, we call that stenosis. And finally, sometimes you can see a tumor or an infectious growth around the heart valves. Additional cardiac testing usually involves something called a myocardial perfusion study or a stress test. This is a non-invasive imaging test that shows how well blood flows through the heart muscle, and it can show areas of the heart that aren't getting as much blood flow, and it can also demonstrate how well the heart muscle is pumping. If it is abnormal, we usually refer patients for a left heart catheterization. This involves the use of a thin hollow tube called a catheter, which is generally inserted into the artery in the leg or sometimes the artery in the wrist called the radial artery. And the tube is guided through the blood vessels all the way to the heart, and then the operator can inject some dye or contrast to make the blood vessels light up on X-ray, and it can be used to diagnose the presence of coronary disease or blockages in the heart arteries, or even to treat blockages. The electrocardiogram or EKG, the echo, the stress tests are generally performed annually and sometimes every other year while the patient's on the transplant list. Other tests include a dental evaluation. So you got to go to a dentist, make sure there's no abscess or cavity that needs to be filled before starting the patient on immunosuppression. We talked earlier about functional status. So patients who are very frail and have trouble walking do badly after kidney transplantation. So it's very important that we evaluate their functional status prior to transplantation. And most often, or at least the local programs, usually use the 6-minute walk test that we talked about. Generally, we also perform a cognitive evaluation. If there's any concern about the patient's ability to make decisions or provide informed consent. And so patients have to be able to demonstrate that they understand the potential risks and benefits of the transplant, the need for lifelong immunosuppression, the need to take the medications and to follow up in clinic. And so if you have someone who has severe cognitive impairment, they may be acceptable from a physical standpoint, but they would need an awful lot of support after transplantation, particularly from a caregiver or a family member, to make sure that they take their medicines and that they come to clinic. Transplant programs will review a patient's adherence or compliance with therapy. So it's not unusual for them to call the pharmacy and make sure that the patient's filling their medications regularly. They'll certainly review the dialysis record and make sure that patients are coming to dialysis and don't miss their treatments. Patient has to have social support in order to receive a kidney transplant. If you don't have someone who can take care of you or bring you to your appointments or be available in case you have a post-operative complication or some sort of complication related to the transplant, then they won't give you a kidney transplant. So you have to have someone who's available to you. You also have to have some financial resources. So, the medications themselves are expensive. You got to make sure that you have insurance and you can afford the deductibles. And you have to address these potential financial barriers before someone receives a kidney transplant. Otherwise, you can run into real problems after. People have lost kidney transplants on many occasions because they couldn't, say, afford the transplant medications, the immunosuppression. There are a number of laboratory tests that are done. They're routinely performed when a patient goes to the transplant program. If you ever ask a patient, hey, how'd the appointment go? They'll say, wow, they drew 20 vials of blood from me. We make sure that they don't have active hepatitis or chronic liver disease. If they do have hepatitis B or C, they have to see a hepatologist and usually undergo a liver biopsy to make sure that they don't have cirrhosis. Some patients, maybe with a history of miscarriage or blood clots or frequent, thrombosis of their dialysis graft or fistula, basically unexplained clotting disorders, may need evaluation by a hematologist before transplantation to make sure that they don't have what's called a hypercoagulable state. And finally, about 3% of people of European descent above the age of 50 years have an abnormal protein in the blood called a monoclonal gammopathy. And there is a chance that this can develop into a malignancy such as multiple myeloma. So if someone has an abnormal protein in their blood, they have to see a hematologist to get clearance before kidney transplantation. As previously discussed, severe calcium deposition or blocked arteries in the kidneys and the pelvis can prevent a surgeon from sewing in a kidney transplant into the pelvic arteries. Evaluation of someone for peripheral vascular disease usually includes an ultrasound of the neck arteries as well as the arteries in the pelvis and the legs to make sure that they are open. As I mentioned earlier, peripheral vascular disease is associated with an increased risk of problems after transplantation. This includes an increased risk of amputation. So in this one study by Snyder, 2006, the presence of peripheral vascular disease before transplantation was associated with increased risk of amputation, kidney not working well because of insufficient blood supply, and a twofold increased risk in mortality following transplantation. What about a combined organ transplant? Well, sometimes our patients need more than just a kidney transplant. Say, for example, if they have type 1 diabetes, they may be a candidate for a combined kidney pancreas transplant. Or if they have liver disease, they may benefit from a combined kidney liver disease. And sometimes those with an ischemic cardiomyopathy, where the heart muscle doesn't pump very well because of insufficient blood supply, are eligible for a combined heart and kidney transplant. In general, the evaluation of potential recipients of a simultaneously liver kidney or heart kidney or lung kidney transplant is similar to the kidney transplant evaluation. Let's review what we've learned today. Absolute contraindications of transplantation include active infection, malignancy, substance use disorder, uncontrolled psychiatric disease, treatment noncompliance, severe cardiac disease, or severe peripheral vascular disease. Relative contraindications include a shorter life expectancy, malnutrition, frailty, obesity, and certain diseases that can recur after transplantation. The initial evaluation, besides the history and physical examination, includes a psychosocial assessment, laboratory and imaging tests, electrocardiogram, echocardiogram, cardiac stress test, and maybe a left heart catheterization. For diabetic patients, in particular, they require an ultrasound of arteries in the neck, pelvis, and legs to look for vascular disease. Frailty is assessed using a 6-minute walk test. If they have any evidence of liver disease or they have hepatitis, they need to see a liver specialist to make sure they don't have cirrhosis. If they've had a clotting disorder or if they have an abnormal protein in the blood called a monoclonal gammopathy, they need to see a blood specialist or a hematologist. It's important to establish that they have caregiver and financial support following the transplantation. Patients should generally be free of all untreated active infections before the transplant, and that's one of the reasons why the dental evaluation is so important. Certain infections such as HIV or hepatitis B or C usually require special considerations and can be relative contraindications to transplantation, but they are not absolute contraindications. Malignancy generally requires a waiting period of a few years following transplant to make sure that the patient is truly in remission. Time for the monthly quiz. Question number 1, name 3 absolute contraindications to transplant. Excellent. So active infection, malignancy, substance use disorder, reversible kidney failure, uncontrolled psychiatric disease, treatment noncompliance, severe cardiac disease, severe peripheral vascular disease,